Hello, I'm Winfried Meissner. I'm working in the Department of Anesthesiology and Intensive Care and also in Palliative Care in Jena University Hospital. And before I start with my talk, I would like to thank the organizers for having invited me to give these talks here. I know you're working under extremely difficult conditions, and therefore I'm really feel honored and I'm grateful that you have invited me to give these talks. Here you can see my potential conflicts of interest. And this is Jena. Jena is more or less in the middle of Germany, near Leipzig, near Weimar. It is a small town with a very old, very traditional university. Goethe and Schiller worked here. We have perhaps the best sausages in the world. You may know the Zeiss company, and we have a not so successful soccer team. In this talk, I will talk about risk factors for severe acute and chronic post-surgical and post-traumatic pain, but I would like to draw your attention also to a couple of other talks related to this topic. So tomorrow I will talk about preventive interventions, and there are two talks on the specific problem of phantom limb pain and about non-medical treatment of this problem. And we will present a project, Pamela, a project between Ukrainian and German experts. So I would also recommend these talks to you. Now I will talk about risk factors for acute post-surgical pain as well as for chronic post-surgical pain, and also talk a little bit about postoperative, persistent postoperative opioid use. Some years ago, we have done this study in the framework of our Pain Out project. Pain Out is a large pain registry where we ask patients immediately after surgery and also 6 and 12 months after surgery about their pain. And what we could show is that on average, patients 3, 6, and 12 months after surgery report in 10% moderate remaining or persisting pain after surgery, and then 2 to 3% they report severe pain after surgery. Here's a very basic picture on the risk factors, both for acute post-surgical pain and chronic post-surgical pain. And now I will go a little bit deeper into these different risk factors and also explain when we have the same risk factors and when risk factors for acute and chronic pain differ from each other. So here are the preoperative risk factors for acute and also chronic post-surgical pain. And the two most important risk factors are pre-existing chronic pain and pre-existing analgesic and specifically pre-existing opioid treatment. These two variables are the most important predictors for patients who will develop much more severe acute pain after surgery and who have an increased risk to develop chronic post-surgical pain. Then we have some psychological risk factors. On one side, it's items like catastrophizing, hypervigilance. That means patients who are really focused on problems with surgery, problems with anesthesia, those patients who say, oh, I'm afraid, I will not wake up after anesthesia, etc., etc. On the other side, it's anxiety and depression. And then we have quite a large number of other risk factors. I only want to stress the topic of substance abuse. We know patients who are known to have abused alcohol and other drugs have an increased risk to develop severe post-surgical pain. And this is relatively new. We know that impaired sleep is also a risk factor for worse post-surgical recovery and severe post-surgical pain. On this slide, you see some surgeries which are associated with increased risk of severe acute pain and severe chronic post-surgical pain. But, and this is important, we have some surgeries which have a higher risk for both problems. Like, for example, amputation. We know that after amputation, patients report often severe acute pain immediately after surgery, but also they have a very high, perhaps the highest risk to develop phantom limb pain, so chronic pain after surgery. On the other hand, we have some surgeries linked to acute, but not necessarily to chronic post-surgical pain, like tonsillectomy or C-section. And on the other hand, we have other surgeries which are also known to have a higher risk to develop or higher risk for patients to develop chronic post-surgical pain like thoracic surgery, breast surgery, and this is a relatively new result of one of our studies also after endometriosis surgery. And finally, we have risk factors which are important for the postoperative phase. And here the most important risk factor is pain intensity, immediate pain after surgery, and also pain duration. However, it's not completely clear if this is really a risk factor or is just an epiphenomenon and might be caused by other problems. Nevertheless, we know that somebody who develops intense pain after surgery has also an increased risk to develop chronic pain after surgery. Another important issue in this perioperative phase is the fact that some patients not only have intense pain, but develop neuropathic pain symptoms. And I will come back to this a little bit later. And also here, psychosocial factors like anxiety, catastrophizing, etc., seem to be very important and to increase the risk to develop post-surgical pain. In the study I mentioned before, we also asked patients, how long have you been in severe pain on the first day after surgery? And you can see here the percentage of time a patient said, I have been in severe pain in the first 24 hours after surgery, and the incidence of chronic post-surgical pain 6 months or 12 months later. And this means it might be not only important how severe the pain intensity is at perhaps some hours, but how long a patient is in severe pain in the immediate time after surgery. And I think this is also an important message. Now I will also talk a little bit on the problem of persistent postoperative opioid use. As you may know, in the US and North America, also in Canada and Australia and a few other countries, there are people who think that our anesthesia and analgesia management might at least partly to be blamed for the opioid epidemic. And there are data from the US that up to 15% of patients who come to a surgery develop a persistent postoperative opioid use 6 months or 12 months after surgery. And if somebody is opioid naive before surgery, it's still between 5 or 6% in these countries. However, we have very few data from other countries. We have very few data from Europe and almost no data from countries outside North America and outside Europe. This slide shows some of the known risk factors for persistent postoperative opioid use. Again, from the US perspective, here you can see again the incidence I just mentioned. We know that some factors like preoperative opioid use, anxiety, depression, again, some of these we have just discussed, are risk factors for persistent opioid use after surgery. So far, it is not really studied if there's also an association between specific types of surgery. This study compared the opioid prescription after 3 frequent surgeries in different countries around the world. Altogether, it included 14 hospitals in 8 countries and looked at almost 5,000 patients. In the US, almost 20% of patients came to a surgery with opioids. In other countries, it was 1%. And at discharge, the pain in North American patients was almost double or 3 times higher than in other countries, partly because length of stay is much shorter in the US than in other countries. And this is perhaps the most important message. In the US, almost everybody leaves hospital with opioids at home for use at home. In other countries, it's a very low number of patients. And this slide shows the opioid morphine equivalents prescribed after surgery in these different countries. And again, you can see that in the US, patients received much, much higher doses of opioids after surgery, after discharge, than in any other country in the world. And we also looked at data in Germany. So we looked on health insurance data, and I don't want to go too into details, but we looked on in a really large data set. And the specific issue at this study was we did not look on the overall incidence, but we also looked on the risk of specific types of surgeries. So the overall incidence in Germany to have at least one opioid prescription in the first 3 months and another prescription in the next 3 months after surgery in patients coming to surgery without opioids, in opioid-naive patients, was 1.4%. So this is 3 times less or 4 times less than in the US, than in Canada. So the first message is, at least in Germany, the risk is much, much lower. And I'm completely convinced in countries in the south and east of Europe, it's even less. But and I think this is very interesting for also for countries outside of Germany. We looked on the relative risk of persistent opioid use after surgery in different types of surgeries. And this is a little bit busy, but you will see, I will explain a little bit. Here again, you see the 1.4% incidence overall. But here in the top of this figure, you see those surgeries with an increased risk. And those surgeries, and number 1, and this is, I think, a very important information also for your country, is amputation. Patients after amputation, specifically after major amputations of the lower extremity, have in Germany a 10 to 20-fold higher risk to take opioids after surgery, even if they came to surgery without opioids before. Then the next important type of surgery is spine surgery, which is much more frequent in Germany than amputation, and a couple of orthopedic surgeries. And I think this is a very important message. Even if the overall incidence is relatively low, there are some types of surgeries which have a much, much higher risk that patients develop a long-term opioid use and sometimes misuse. And we should look specifically and follow up patients after these types of surgeries. And I again refer to the talks on amputation and phantom limb pain from my colleagues. We also looked on other risk factors in the history of these patients. This was on one side again, like we already discussed in acute and chronic post-surgical pain. Substance abuse, alcohol abuse, it was pre-existing chronic pain, and it was prescription of antidepressant drugs. As in these insurance data, we do not have data on the exact type of pain management during surgery. We also did another analysis where we looked on data of our registry, of the pain out registry, and combined these data, which focus on the immediate period of surgery and anesthesia on one side, and a long-term follow-up from insurance data. So we combined two databases, the pain out database and the insurance database. And we also combined insurance data with data from the pain out registry I have mentioned before. So we could combine information about anesthesia itself with long-term outcomes. And it turned out that type of anesthesia was completely independent or not associated with persistent opioid use after surgery. However, we saw that the fact that patients received opioids after surgery increased the risk, although the risk increase was very small. It was only 4%. And it turned out that this risk was only increased when opioids were given in patients with moderate pain or with mild pain, which normally should not be the case. There are other risk factors which are not well studied. We have some data that perioperative infections, wound infections, might be linked to prolonged pain after surgery. There are some new data that anti-inflammatory drugs, for example, ibuprofen, but also dexamethasone or other anti-inflammatory drugs might also impair the healing process and damage and so prolong pain after surgery. We have some data on genetics, which are not, from my point of view, not really convincing. And we have data on sex and age. First, we cannot influence these factors. And second, they are relatively small. So the differences between men and women are relatively small. Women have a slightly higher risk to develop acute pain and chronic post-surgical pain. But again, the increased risk is relatively low, and from my point of view, without clinical relevance. So how to identify patients with an increased risk to develop severe pain after surgery? So far, we do not have a really well accepted or established score with a proven high sensitivity or specificity. But you can do something very simple, and this is what I recommend: to ask 4 simple questions to your patient. Are you in severe pain already before surgery? Do you have a chronic pain condition, for example? And if this is the case, do you take painkillers for a longer period of time? Specifically, do you take opioids already before surgery? Third, is one of the so-called surgeries at risk planned in this specific patient? I've talked about some of these surgeries with an increased risk to develop severe pain. And fourth, is the patient concerned about his or her medical condition? About the intervention? Is he or she afraid not to wake up after anesthesia or to develop a severe complication? So if some of these points are answered with yes, then the risk to develop severe pain immediately after surgery and chronic post-surgical pain is clearly increased. So let me summarize my talk. I have talked about risk factors for severe acute and chronic post-surgical pain. We know that preoperative risk factors like chronic pre-existing pain, long-term treatment with painkillers, specifically opioids, are the most important risk factors. And we also know some psychological factors like catastrophizing, anxiety, and depression. And the nice thing is these factors can be obtained before surgery by talking with the patient. I've shown some intraoperative risk factors like nerve lesions, like non-traumatic surgery, and specifically type of surgery. And here it's important that some types of surgeries increase the risk to have acute pain after surgery. Other types of surgeries increase the risk to develop chronic post-surgical pain. And some surgeries, specifically amputation, increases both risks or both the risk of severe pain immediately and later on after surgery. And after surgery, we know that high pain intensity on one side and long-lasting acute pain on the other side is also associated with an increased risk to develop post-surgical pain for a longer period of time. And specifically, a patient who develops neuropathic pain should be followed up closely, and I will talk on this topic in my second talk. Persistent opioid use after surgery is, from my point of view, a problem in the US, in Canada, but not in Europe, and certainly not in your country, in Asia and Africa. Risk factors are similar, but we know some high-risk surgeries, again, amputation, spine surgery, and some orthopedic interventions. But if opioids are adequately used, they do not increase the risk to develop persistent pain after surgery or persistent opioid use. Thank you very much.